Welcome to this educational overview of pheochromocytoma, a rare and potentially serious condition. In this session, we will explore what pheochromocytoma is, its causes, symptoms, diagnosis, and treatment options. This condition, though uncommon, can significantly impact health due to the excess production of catecholamines like adrenaline and noradrenaline by tumors in the adrenal glands. Let's dive in and understand how this disorder affects the body and how it is managed effectively. Pheochromocytoma is a rare, typically benign tumor of the adrenal medulla, the inner part of the adrenal glands, which produces excess catecholamines, primarily adrenaline, epinephrine, and noradrenaline, norepinephrine. These tumors are responsible for paroxysmal or sustained hypertension due to the overproduction of catecholamines. The incidence is about 2 to 8 cases per 1 million people per year. It accounts for 0.1 to 0.5% of all cases of hypertension. The peak incidence occurs between the ages of 30 and 50 years, but it can occur at any age, even in children. Both males and females are affected, with a slight predominance in females. Pathophysiology of this disease. 1. Catecholamine secretion. Pheochromocytomas primarily secrete epinephrine and norepinephrine into the bloodstream. These excess catecholamines lead to the clinical manifestation of hypertension and other systemic effects, such as tachycardia, sweating, headaches, and more. 2. Mechanism of hypertension. Alpha receptor stimulation. Norepinephrine stimulates alpha-1 receptors, causing vasoconstriction. Beta receptor stimulation. Epinephrine stimulates beta-1 receptors in the heart, leading to increased heart rate and cardiac output. Renin release. Catecholamines also stimulate renin secretion from the kidneys, increasing blood pressure via the renin-angiotensin-aldosterone system. Clinical presentation of pheochromocytoma. Classic triad, high-yield exam point, asterisk. 1. Headache. 2. Sweating, diaphoresis. 3. Palpitations. Other symptoms, asterisk. Paroxysmal hypertension, episodic, or sustained hypertension. Anxiety, tremor, pallor, flushing. Orthostatic hypotension, especially after prolonged alpha blockade, hypoglycemia. Weight loss. Triggers for attacks, asterisk. Surgery or anesthesia. Certain medications, e.g., beta blockers without prior alpha blockade, decongestants, exercise or emotional stress. Diagnosis. Biochemical testing, high yield, first line, plasma-free metanephrines, most sensitive, alternative, 24-hour urine fractionated metanephrines and catecholamines. Avoid caffeine, nicotine, and certain medications before testing. False positives, stress, illness, some drugs. Imaging, localization, CT scan abdomen, first choice for adrenal tumors, MRI, if contrast contraindicated or pregnancy. Functional imaging, for metastasis, extra-adrenal, MIBG scintigraphy. PET scans, FDG, DOPA, DOTATATE, genetic testing. Indicated for age less than 45 bilateral or extra-adrenal tumors. Family history. Common genes, RET, MEN2, VHL, NF1, SDHX. Treatment of pheochromocytoma. 1. Preoperative medical preparation. Before surgery, blood pressure and catecholamine effects must be controlled. Alpha blockade first. Main step. Phenoxybenzamine, non-selective, irreversible alpha blocker. Sometimes selective alpha-1 blockers like doxazosine are used. Purpose. Control hypertension. Prevent intraoperative hypertensive crisis. 2. Then beta blocker, only after alpha blockade. If tachycardia persists, propranolol or similar beta blocker. Never start beta blockers before alpha blockers because unopposed alpha stimulation can cause severe hypertension. 3. Volume expansion. Patients are often volume depleted due to chronic vasoconstriction. High salt diet. IV fluids before surgery. 4. Definitive treatment is surgery. Surgical adrenalectomy. Tumor removal, usually laparoscopic if localized. 5. If malignant or metastatic, options may include chemotherapy, radiotherapy, targeted radionuclide therapy, e.g., MIBG therapy. Now let's summarize everything. Pheochromocytoma is a rare tumor of the adrenal medulla that secretes excess catecholamines, mainly adrenaline and noradrenaline. It typically presents with episodic hypertension, headaches, sweating, palpitations, and tachycardia. The classic triad is headache, sweating, and tachycardia. Diagnosis is mainly by elevated plasma-free metanephrines or urinary catecholamines, followed by imaging such as CORT or MRI. Treatment begins with alpha blockade, usually using phenoxybenzamine, followed by beta blockade if needed, and then surgical removal of the tumor. A key rule is, never give beta blockers before alpha blockers, because this may trigger severe hypertensive crisis. Thanks for watching. If you found this summary helpful, don't forget to like, share, and follow for more quick medical reviews and high-yield topics.